Hello, this is an interesting case involving extraction of a mandibular first and third molar. We're extracting the roots. The teeth had decayed underneath a fixed bridge, and actually the bridge had broken off at the gum line. So there was no pain since the patient had had endodontics on those teeth. So I'm going to extract those roots and graft the sockets with platelet-rich fibrin and bone graft material. And I'm going to place a resorbable collagen membrane on top of the graft. I'm going to let that heal, and in 6 months we're going to come back and I'm going to place implants in the first molar and second molar sites. I'm not going to do anything with the third molar. So in this episode we're going to talk about the extraction, the grafting, and the suturing.
I have some incredible news. You can get your CE training online. Yes, you heard me correctly. You can get your CE credit online, all from the comfort of your own home. All you gotta do is click the link in the description and go to dentistrymasterclasses.com. It only costs $20 a month, but right now we are giving it to you for 99 cents. You will not be able to beat this offer. So click right now and be prepared to have your life change for the better.
So here's before and after of the first molar, the graft, which is a mixture of platelet-rich fibrin and Maxius cancellous cortical bone. I like to mix them because and I've done some grafting with only platelet-rich fibrin, and that's also excellent. And I know some excellent surgeons that just use platelet-rich fibrin. I like to mix them with a bone graft material because it gives it some body, and it's easier for me to fill up the socket in a uniform way. And then you can just put a slab of platelet-rich fibrin over the graft material. I always like to put a resorbable collagen membrane over the graft because it seems to make it flat once it's healed, when you're going to place the implant. So you can see the teeth had endodontics, and we've grafted it here. So first we're going to give painless and profound local anesthesia. You can look up that video on YouTube or in the library of dentistrymasterclasses.com. It's critical that the teeth and the bone around the teeth and the soft tissue are profoundly anesthetized. And an intraligamental injection is very important most of the time. So anytime I'm doing something major like extracting a tooth or performing endodontics or even a crown prep, most of the time I will do an intraligamental in the mandibular in addition to a mandibular block. So watch those videos. Now we're drawing the patient's blood to create platelet-rich fibrin. So you'll draw the blood in the vials and then spin it down, and we always spin it 2 cycles, and then you'll have the platelet-rich fibrin clot on top of the entire blood clot. We have a video on how to make platelet-rich fibrin in the library of dentistrymasterclasses.com. And as you know, platelet-rich fibrin just enhances healing of the graft. So we're drawing it in the vials. You always want a balance. So you want a vial here and a vial here and a vial. If you have a vial here, you need one here. If you have one here, here, you also need one there. So I normally do either 2, 4, or 6 vials. And we always spin it twice. We've just found when we spin it just 1 cycle, the PRF clot does not form adequately many times, so now we just automatically spin it twice. So I'm measuring the distance between the alveolar crest and the inferior alveolar nerve, and that's about 12 millimeters. Just so I've got that in the back of my mind. It'll be more important once we've grafted the sockets and they've healed and we're coming back and placing the implant. Now, how do I determine how long? If I've extracted a multi-rooted tooth, then I do not place the implant at the same time I extract the tooth. I graft the socket and I wait 6 months for the graft to heal before I place the implant. Now, if I'm extracting a single rooted tooth, if I can extract the tooth straight out of the socket, I prefer to place the implant at the time of the tooth extraction. And I use the easy extract system, if I can, to extract the tooth straight out of the socket, so I preserve the facial and the lingual or palatal bone. If it's a multi-rooted tooth, you're wanting to place the implant most of the time in the furcation area. It's very difficult to get the implant at the right depth, so that once all the bone has healed, so the socket has healed, the bone level, the new alveolar crest, covers all the threads. And it's also hard to drill that osteotomy in the furcation between the roots of the teeth. So I just take the tooth out, if it's a multi-rooted tooth, graft it, and I let it heal 6 months and then come back and place the implant. So in this episode, the only thing I'm going to be doing is extracting the first and third mandibular molar, grafting them with PRF and bone graft, placing a resorbable collagen membrane, and suturing. Then we're going to let that heal and then come back in 6 months. You can watch that episode on dentistrymasterclasses.com when we've done it. So first, I'm incising and around the teeth and reflecting that flap, and it's little pieces because it's decayed. Very difficult extractions. You want to be careful that you don't incise past the sulcus on the lingual, because you don't want to take any chances on damaging the lingual nerve, and you also don't want to take a chance on damaging the inferior alveolar nerves. So when you're doing any cutting or sectioning of the tooth, you want to know the distance from the alveolar crest, which would represent the top of the coronal part of the tooth roots, to the inferior alveolar nerve, so you don't come close to that. So here I'm sectioning that third molar. This is a high-speed handpiece with light touch. Now you won't create an air embolism on the lingual if you don't reflect that lingual flap. So keep the attached gingiva connected to the alveolar crest. Don't reflect a big flap and then use a high-speed handpiece. If you do, the air from the handpiece could create an air embolism. So be sure that flap in the attached gingiva area is connected to the bone. You don't want to reflect it away from the bone. So I'm sectioning through the tooth, facial, lingual, separating the distal root from the mesial roots. Now I'm incising all the way to the first molar and reflecting that flap. I know going in it's going to be a tough extraction because it's tooth roots in a tooth that's been endodontically treated, and it was endodontically treated many years ago. So you know those roots are going to be brittle. So now what I'm doing in the third molar area, because I'm not going to place an implant there, I don't mind removing a little bone on the facial. So this is a small, long shank, round burr, lots of water, light touch, and just removing a little bone around the tooth so I can place my elevator. You can see where I've separated the roots, and I'm using periodontal elevator to try to remove those roots, and you can see they're coming out in pieces. So when that happens, you just have to go back in and remove just a little more bone to get a purchase point. Remember, if you're trying to elevate a tooth, you've got to have a space to move it into, so you want to remove a little bit of bone on the distal and a little bit on the mesial so you can create a purchase point to elevate the pieces of the tooth. You want to separate the mesial roots from the distal root so you can elevate them separately. Just removing a little bit of very small amount of bone just to get a purchase point for my elevator. Starting to get movement. It's a tedious process to remove a brittle tooth root. So there's the roots of the tooth moving in little pieces. Now I'm working on the first molar, and I'm seeing if it'll elevate. Now the platelet-rich fibrin has spun down, and this yellow part is the PRF. So you want to separate it from the blood clot and place it on this perforated tray. Remember, the purpose of the platelet-rich fibrin is to enhance healing of the bone in the socket. You place these little caterpillars on that perforated tray, then put that lid on top of it, and that squeezes the serum out of the PRF clots, and it drains into the tray below. Now I'm sectioning the first molar, facial to lingual. Remember, it's very important if you're using a high-speed handpiece that if you're touching the bone at all, you have a very light touch and lots of water, and you do not reflect the flap on the lingual, because you don't want to create an air embolism. It's not the end of the world if you do, but you just don't want to. And that's how you avoid it. Be sure that attached gingiva remains attached on the lingual. So I'm trying to elevate these pieces. Now, you'll cut just a little bit into the bone right here with that small round burr on the distal of the tooth. I want to preserve the facial bone and the lingual bone, but since I'm grafting, I don't mind removing just a little bone on the distal so I can get a purchase point for my elevator. If you've got a root in there that's flat with the coronal part is flat with the alveolar crest, you don't have a purchase point, and you don't have a space to move that root into. So you've got to have a place to have a purchase point for your elevator, and you normally have to have a little space to move whatever piece you're trying to elevate into. Okay, so there's the distal root. Now, when I'm removing this root, I want to be sure I've got a little space here on the mesial, and I've now got the space to move it into. So there are the two pieces of that root, the mesial buccal and the mesial lingual root and the distal root. Then I'm curetting out any little pieces and putting my squeezed down platelet-rich fibrin into this dapping dish. Now you take this perforated lid off of the tray, and you suction the PRF serum into a syringe, and I'm going to use that to wet the bone graft material here in a minute when I add that to the platelet-rich fibrin in the dapping dish. So I'm going to start with just 2 of the PRFs. I have four, and I'm tapping that cortical bone demineralized maxius. I'll also use bioos sometimes, but this is a good bone graft material. And I'm wetting that bone graft material with the serum. And then I'm using my scissors to cut the PRF up into small pieces so it will mix with the bone graft material. Then I'm going to add the other 2 slabs of PRF. Just cut it up into pieces. And as I said, I like adding bone graft particles to the PRF because it's kind of like working with sand rather than working with jello. If you're only working with PRF, to me it's like working with jello and hard to pack it into the socket and get a flat surface. You can put a slab of PRF over the coronal part of the graft in lieu of a resorbable collagen membrane. I like to mix it like this and then put a resorbable collagen membrane over the coronal part of the graft, because whenever I go back in to place the implant, I've got a nice flat surface. So I'm primarily concerned with the first molar site because I'm not going to place an implant in the third molar site. So I want to be sure I've got plenty of graft for the first molar site, and I'm filling that first, and I'm using these pluggers to flatten it out. You can see even like this, it's kind of a trick to fill it uniformly. You want to plug it down into the extraction site roots. And I'm mixing a little more with my PRF and bone graft for the third molar site. And I'm grafting that site kind of while you're at it. because I'm not going to place an implant there, but you never know when you might need a site for an implant. So while we're extracting the teeth and grafting, if I've got some graft material left over, go ahead and graft the third molar site. Now, if I didn't place graft material in the third molar site, I would place a resorbable medicated gauze so the patient doesn't get a dry socket. This will do the same thing that the resorbable medicated gauze does as far as keeping the patient from losing the clot and getting a dry socket. So just flattening that out. Got a little piece of bone right there. I'm just barely elevating that flap on the lingual. Reason I'm doing that is so I can place my resorbable collagen membrane under that flap. So it's not just flat on the extraction site and the graft, it's covered by the graft, which lets you pull the graft over the resorbable collagen membrane and tucks it in to protect it. So I place the resorbable collagen membrane on the extraction site and eyeball it to figure out how large I want the resorbable collagen membrane to be on top of the graft, so I can tuck it under the lingual and the facial tissue, and it covers the site, but I don't have too much. See how I'm covering it with the lingual tissue, lingual flap, and the facial flap. I like to cut the corners off, just makes it easier to control. This is 3/0 resorbable gut suture. Now you could use chromic gut. I don't use chromic gut because chromic gut lasts for 2 weeks and it pokes the patient's tongue. I mean, every now and then I might use it, but normally I use 3/0 gut, and that's going to stay in place for 3 to 7 days and then dissolve, and that's adequate for this. Now when you're suturing, you want to do 3 wraps, pull, then 1 wrap and pull. 3 wraps towards you and pull, and then 1 wrap away from you and pull, and then 1 wrap towards you and pull. So again, it's 3 wraps towards you and pull, 1 wrap away from you and pull, and then another wrap towards you and pull. Now the 3 wraps the first time is something I always do because it makes that pull stable. If you just do 2 wraps and you pull, many times that will loosen up and it's not tight on the tissue. 3 wraps, that first pull is going to be, the first part of the knot is going to be stable and tight on the tissue. Now you don't want blanching of the tissue. If you do, the suture will probably pull out. You just want it snug. Using these tissue forceps to lift the tissue, they've got the little points in them so you can grab the tissue. See, 1, 2, 3, 1, and then 1. 1, 2, 3, 1, and 1. If possible, you want the knot to be on the side of the wound. You'd rather not have the knot in the middle of the wound because it collects a little plaque and what have you, and so it's just a little cleaner if you can keep the knot on the side of the extraction site. See, it's not in the middle of the extraction site, it's over here on the side. Using the tissue forceps so I don't suture into the resorbable collagen membrane. Whenever you're suturing, also you want to take a deep bite. You don't want to bite to right here, it'll pull out. Take a deep bite on both sides of the incision. 1, 2, 3, 1. So 1, 2, 3, pull, 1, pull away from you, then 1 towards you and pull. And that's a good stable knot. A big bite. You'd like a couple of millimeters at least on each side of the incision where the needle goes in and comes out. Now I'm not trying for primary closure. that's a point of debate. Some people say you want primary closure. That means you want the flap to connect. I don't want to have this giant reflection to loosen the flaps for primary closure. So I've done it like this for 40 years and it works well. And I'll show you on this case in 6 months that tissue heals very nicely. So as long as you've got either PRF or a sorbal collagen membrane over the graft, you're fine. I mean, you don't want it wide open, but if you've got a little space between the flaps, that is not a big deal. I think that the blood supply to the tissue is more important, for not reflecting this giant flap. A big bite, and 1, 2, 3, pull, 1, pull away from you, then 1 towards you again, pull. You can do it either way. You can either go 1, 2, 3 away from you, and then pull, and then 1 towards you and pull, and then 1 away from you and pull. You want the knot to be flat. You don't want the knot to be turned. You want it to pull well once you get to the tissue. So it seems like most of the time it's 1, 2, 3 towards you, pull, 1 away from you, pull, and then 1 more towards you and pull. And that creates a nice even knot, like a square knot and not a granny knot. So here's before and after the graft, and this is before and after the suture. You can see there's a little space between the flaps, and I'm not worried about that at all. In 6 months we're going to film this once it's healed, and the extraction sites and the implant placement, and then we'll go on with the abutment and crown placement. So you can tune into that in dentistrymasterclasses.com in about 6 months. So that's the Dental Minute. These techniques work, and they work every time.